Good afternoon and welcome. We are excited to have you join us for the Immune Deficiency Foundation's first educational event of 2025. Today, we are kicking off our diagnosis-specific series with a discussion on IPEX syndrome, led by Dr. Rosa Bachetta from Stanford School of Medicine. My name is Emma Mertens, and I'm the Program Manager for Education at the Immune Deficiency Foundation. On behalf of IDF, we thank you for tuning in to this virtual event. Throughout this series, we'll explore some of the lesser-known types of primary immunodeficiency, providing diagnosis-specific information and support to the PI community. In offering these programs, we aim to move forward in our vision of a healthier day every day for every person living with immune deficiency. A brief disclaimer. Please remember that information presented during this meeting is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted friend and source to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. And now I am so pleased to introduce our presenter for today. Dr. Rosa Bachetta is a professor of pediatrics and stem cell transplantation at Stanford School of Medicine. Her research focuses on discovering the underlying genetic bases for immune dysregulation in some of the rarest forms of primary immune deficiency and developing novel cell-based therapies for patients living with these ultra-rare disorders. Welcome, Dr. Bachetta, and thank you so much for joining us.
Thank you very much for inviting me to give this lecture, informative lecture. And good afternoon, everyone, or good morning for who is on the West Coast like me. Okay, I'm going to share the slide now, and I am going to start. All right, so we are going to talk about IPEX syndrome. I don't have anything in particular, any conflicting interest to disclose about this subject. And so what I will do is to give you an introduction on primary immune regulatory disorders, among which IPEX syndromes stands, and to also give you an idea of the natural history of the disease, immunological characterization, and how this can help in diagnostic of the disease. And then I will touch on mechanistic insight to finish up with treatment information, which are, let's say, standard treatment or gene therapy treatment, which are present and future for these patients. So the immune system has two main functions. One is the ability to clear infection, to fight infection due to external pathogens. And the other one is to prevent the aggression of the immune system on all the cell tissues and organs, presenting self-antigens. When these two important functions are impaired, and this can happen because of genetic mutation, we have respectively primary immunodeficiency or autoimmunity. And you know, really in the homeostasis, so in health, what you have is always a perfect balance between effector functions, which are fighting external infections, or regulatory function that are tolerant towards self-tissues and also towards non-harmful external antigens like food, for example, or pollution that we have in the air and so on. We come in contact through the skin or the lungs and so on. And when we have a monogenic disease of the immune system, we can have different situations in which inadequate number of T regulatory cells are present, or they are defective in their function, or also the effector function can be altered and less sensitive to regulation, like in case of high increased inflammatory environment. And in this case, we have a disbalance between the two functions, the effector function and regulatory function, and therefore this imbalance generate immune dysregulation. And so through the years, we have well-characterized primary immunodeficiency, the traditional primary immune deficiency, which are the cluster of diseases in which the individual is not able to fight infections. But now we know that there are primary immunoregulatory disorders where there is altered immunity and there is autoimmunity. Leading cluster of these primary immunoregulatory disorders are the so-called T-regopathies, so diseases in which the T regulatory cells, the specific cell types are altered, and then also cluster of diseases in which there is the predominance of autoinflammation and increased inflammatory cytokines. As you can see, there are different genes that are, these are the list of genes, very limited list of genes that are impaired, mutated, and responsible when mutated of all these diseases. And also, as you can see, interestingly, these clusters are indeed overlapping very much. And this is a big challenge for the diagnosis and especially for the treatment and management of these patients. These diseases are increasing over time. Is not that they are increasing actually, but we are more able, we are better at diagnosing these diseases thanks especially to the genome sequencing that as a diagnostic tool really is very much more common now than in the past. And therefore, physicians, when they see an early on situation of altered infections, increased infection and susceptibility to infection or inability to fight infection, or also increased autoimmunity at the early on in life, they go for gene sequencing. And then this is the way that, more typically these diseases are diagnosed and detected. There are over 400 genes that are responsible for overall all this cluster of diseases, and the primary immunoregulatory disorders account for about 1/3 of them. So IPEX syndrome, the IPEX stands for immune dysregulation, polyendocrinopathy, enteropathy, and is an X-linked disease, meaning that is also only manifested in male subject because the gene is basically carried in the X genome, and therefore is carry over generation through the mom, is due to loss of function of FOXP3 gene. So FOXP3 is a very important gene, essential gene for the generation of functional regulatory T cells that are coming out of the thymus very early on in life. As soon as we are actually still in utero, they are very important for immune regulation, and then early on in life. So this IPEX has really become the prototype of T regopathies, where this peripheral mechanism of regulation is altered, and also is the prototype of genetic autoimmune diseases. And knowing more about IPEX has really be instrumental for understanding and diagnosis many other of these primary immunoregulatory disorders. So what are T regulatory cells? T regulatory cells are comprised within the white blood cells of in our blood, and within the lymphocyte, and within the T lymphocyte, which are called CD4 positive T lymphocyte. And interestingly, they are present, in very small percentage among the CD4 positive T cells. So this is actually the percentage, 4 to 7% is the percentage that we can detect these cells in the blood. However, we know that in the tissue, like for example, in lymph node or in the bone marrow, or very much, at the site of encounter with other antigen, non-self antigen and self antigen, like in the gut or in the skin, these cells are much more abundant than that. These cells are present, they have the peculiarity is that they have many different functions of regulation and inhibition of many other cells in the immune system. So they can regulate and inhibit and, keep in check other T cells, but also antigen-presenting cells and also B cells via many different mechanisms which are mediated by receptors that are present on the membrane of these cells, and therefore these cells needs to be, in cell-cell contact with the target of the regulation, but also via certain cytokines or metabolic changes that can be exerted on the distance. So interestingly, this disease, the first description of this disease was in 1982. With a big description, only clinical description of several generations in a family, with several patients affected by the disease, and all male, of course. And interestingly, this paper described really what we now know is the spectrum of the disease, comprising individuals that have, very severe and fatal disease in infancy, very early on in infancy, and other which can survive and reach adulthood and be not healthy, but still, have a less severe form of the disease. But then, from 1982, it went up to the beginning of 2000, when it was the disease and the mutation of the disease was discovered in patients, and also in a natural mouse mutant that was discovered to develop this. This is called the scurfy mouse. A disease we know especially of the skin and the gut of these mice that died very early, and they were, discovered to have the mutation in FOXP3. And then a few years later was really made the connection between this gene, FOXP3, and the T regulatory cells and the clinical phenotype of the disease. So this was really, the beginning of the awareness of this disease entity. And then after that, of course, there were work in looking at the immune regulation and the dysfunction of these T regulatory cells, but also T effector cells affected, And then it was discovered that the mutation indeed does not alter the protein expression, but so the protein can still be expressed, but is dysfunctional. And then the first patients were transplanted from another donor, so from allogenic donor, and it was discovered that only a few cells of the donor, a few T regulatory cells of the donor, which are healthy, can allow the control of the disease manifestation. And this gave us the rationale to accept the gene therapy that is now ongoing and that I will talk about that. However, the bone marrow transplantation of hematopoietic stem cell transplantation remains one of the main treatment and standard treatment and curative treatment for this disease. And I will touch on that more specifically. And also we know now that the disease spectrum is very broad. We have more tools in addition to the gene sequencing. We have more tools to diagnose the disease and understand the severity of the disease. And also we have more to come in the field of gene therapy. So overall, you know, disease is IPEX is a rare disease, but as usual in this field, the more you look for and the more you diagnose, and really you realize that the diseases are not so rare as initially thought. So putting together all what the cases that have been described so far are about 600 with a number of different mutations, probably about 200, and still an overall mortality which is pretty high. But the real prevalence of the disease is really difficult to estimate, and you know, these are just numbers that are estimated and not precisely calculated. So the gene is characterized by 11 exons and with different domain. As you can see, importantly, the gene mutation, and this is just a partial representation, but the gene mutation are present all over the gene. They can be, you know, in any of these domains. Let's say the hotspot can be intended the fork head domain. So these red exons which go from E9 to E11, where more frequently patients are observed with the disease. And so how do we really diagnose this disease? I think I want to stress that the main you know, characterization and main way to diagnose is really the clinical presentation. Typically, this disease manifests very early in life. As you can see, this little pie chart with that was done out of 96 patients with IPEX, with FOXP3 mutation. You can see that almost half of them had the onset at less than 1 month of age, and half of them really between 1 month and 1 year, and only few above 1 year. We now know that probably the more than 1 year, it's now a little bit broader than that, but still, you know, the typical manifestation of IPEX is the early onset. So these children are born with more than, you know, 90% of them with a severe enteropathy that manifest with diarrhea, inability to absorb food, milk, and very serious consequence in terms of dehydration and so on. And also about half of them manifest with type 1 diabetes. Specifically, IPEX is one of the main cause of neonatal diabetes, and they typically have skin manifestation, which can also be very severe, with eczema, atopic dermatitis, and so on. But the other possibility of manifesting the disease is also the addition of blood disorders, especially cytopenia or red anemia, autoimmune anemia, or deficiency in platelets or neutropenia. And lately, more and more cases are also observed with kidney disease with early onset. And in few cases, we also have neuromuscular autoimmunity, which can be detected. And also, basically also, for example, liver can be a target of the disease. So autoimmune hepatitis can be another manifestation of the disease. Overall, how is it possible that one gene can really alter so much our health and our immune system? There is actually a chain of events that happen. So one is that the T regulatory cells are altered, and not only they are dysfunctional, but they basically change and become themselves effector cells. It's starting to secrete pro-inflammatory cytokines or cytokines which are very similar. They are called the Th2 cytokine or Th17 that really are similar to the cytokines that are present in allergy. And that's why, many of these manifestations in IPEX are also similar to allergic manifestation. And so you have increase of autoreactive T cells that tends to expand in the peripheral blood and in the tissue, and always maintain this phenomenon of aggression of different tissue. And this also elicit in the production of autoantibodies because of the loss of peripheral B cell tolerance. So the B cells are the one that can make antibodies. Again, here you have good antibodies that go against pathogens, but you also have bad antibodies that go against the tissue and cause the tissue damage. So overall, this mechanism of action just because of one gene mutated is really very complex and also difficult to treat. In addition to the clinical diagnosis and, of course, the genetic diagnosis. So the clinical diagnosis should drive the question and should drive the request for the genetic diagnosis. But then many times when we have a genetic diagnosis, maybe we have a new mutation, for example, and we don't know exactly if this is really responsible for an IPEX manifestation or not. So immunological evaluations are very important to give a hint of to complete the diagnosis and also to sometimes help in understanding the severity and the prognosis of the disease. So typically within the lymphocyte, there is not much alteration. Sometimes there is an increased number of lymphocytes which are also not responding to treatment, and typically the CD4 positive T cell compartment is more than the CD8. The eosinophils are increased as well as the IgE are elevated, and this again are expression of a Th type 2 immune response, which can also be present in allergic individuals. you have presence of autoantibodies and overall elevated pro-inflammatory cytokines. Looking for the expression of the protein or the presence of T regulatory cells in the blood that can be done by immunophenotype, searching, staining for CD25 high and CD127 low cells, may or may not help in the diagnosis because in many cases these cells are detectable. In some can be lower the normal level. Importantly, what we have seen by study really many patients over 20 years is that there is this epigenetic marker, which is called the Treg specific epigenetic region, which is in the DNA of our lymphocyte. Then when he's demethylated, this is very specific of IPEX syndrome patients. So you can see here the quantification of this demethylation, so of cells that have demethylation of this region in the DNA in IPEX syndrome in green versus normal donors. And the one in pink are pediatric normal donors. And so really you can see that there is a very significant difference. And so this is, we believe, a very important tool for understanding whether, a FOXP3 mutation is really responsible of the immune dysregulation of T regulatory cells. And importantly, this elevated TSDR is also seems to be correlated to the disease severity. So the typical IPEX syndrome, the patient that have a more severe disease are also the one with higher TSDR. And as I said before, this patient have autoantibody in the serum. The autoantibodies can be the one that are also present in many other individual with autoimmunity. For example, all cluster of autoantibodies against thyroid tissue or autoantibodies that are present in type 1 diabetic patient, but without FOXP3 mutation, which of course are more common. And or they can also have specific autoantibodies such as anti-harmonin antibodies that are going towards, in this case, specific structure, the harmonin which is present in the gut. And we don't know exactly why, but in IPEX, this is a big, molecule which is target of the autoantibody production and is very helpful for diagnosis. Interestingly, so when we, a big wish of many physicians and also family is to understand when you have, the mutation identified and where the mutation is in the gene, to understand if this can correlate with a more or less severe manifestation and a better or less positive prognosis. Interestingly, as also it happens in this genetic diseases, is very difficult to have a clear genotype-phenotype correlation. And this quite complex table, which is also present in a paper, so you can go back there and look more with more time. But basically the message is that you have individuals, even within the same family, so even siblings with the same mutation in FOXP3 that have different clinical manifestation. Like, for example, here you see that there are two, they have type 1 diabetes and enteropathy, muscular weakness, but other individuals with the same mutation have completely different manifestation, like renal disorders and autoimmune hemolytic anemia and so on. This, of course, complicate the picture, and there is still a lot to understand on how the mutations leads to the clinical manifestation. Coming to treatment, so the schematic, basically in summary, the different approaches that can be adopted to fight against this disease once it's manifested are drug-based approaches or cell-based approaches. When we talk about cell-based approaches, we can, the source of the cells can be allogenic, meaning from a different person that becomes a donor, for example, in case of allogenic stem cell transplantation, or autologous, so the same cells of the patient can become the source of the treatment, and I will go to that. When we talk about drug-based treatment, so when a patient is very sick and present with acute manifestation, first of all, the patient needs to be, metabolically and hormonically compensated because of all the problem, the acute manifestation that he has. And then it's necessary to give immunosuppression, so to use drugs that can immunosuppress this excess of immune response against tissues that the patient has. So throughout the years, many different, typically, steroids is definitely a very good drug that is and efficacious, that is used as a first line of treatment. In the past, then there were other drugs like cyclosporine and tacrolimus that were, very efficacious in the short term. But it has been observed that actually rapamycin is very effective and very beneficial even alone or in combination with steroids for controlling the autoimmune manifestation and the autoinflammation of IPEX, with the peculiarity that really rapamycin seems to be more selective against T effector cells, whereas preserving some of the function of T regulatory cells in case residual function can be present and can even trigger over time different type of immune regulatory pathway within the cells. So if the patients have tolerated this drug, I think that's a good drug to give. There are now even more targeted drugs which have been used with benefit. However, there are no really standard treatment and large studies because, of course, the disease is rare and is difficult to really have overall, large scale responses. And also these patients are very heterogeneous, so they may respond in different ways. But for example, JAK inhibitors or CTLA-4 infusion protein, abatacept, has been used with success, as well as, other approach is also to use anti-CD20 to dampen the production of autoantibodies. When we talk about cell-based treatment, so this is using stem cells that are coming from a healthy donor. This, of course, the first question is to choose a donor that is compatible with the patient in terms of tissue compatibility, HLA compatibility, and also this approach requires the use of conditioning and immunoablation. So we have to wipe out the immune system of the patient in order to replace it with the healthy one. And this is quite, an invasive, part of this approach. And then the transplant can result in mixed chimerism, and it's not really clear how much the mixed chimerism can be sufficient over time. And also some patients can face rejection of the transplant and therefore coming back of the disease. Overall, however, so these are data that I present you over 96 patients, 58 transplanted with stem cell transplantation in red and immunosuppression only in black. So as you can see here, the percentage of survival seems to be in favor of the immunosuppression only. And this here we have a 15 years follow-up for the transplant and 25 for immunosuppression. But overall, if you look at the disease-free survival, the patients that are transplanted and are successfully transplanted remain absolutely superior to the immunosuppression only, with about 60% of success. So these are data that are being produced out of these 96 patients that all over the world, because yes, I forgot to say, but basically the diseases can be present in any part of the world, but also have been confirmed by other studies which are mentioned here with similar results. So, and then we come to the present and the future of treatment, which are the use of autologous cells, so the use of the cells of the patients and which cells can we use and gene modified in order to give them back to the patient and cure the disease. So we can use the T cells of the patient, or we can use the stem cells. And these are two different approaches, and I am going quickly through that. So what we do now on the T cells is we take all the T effector cells of the patients, which are collected from the blood, and we put in these cells a construct, so a gene construct that is containing a normal FOXP3 gene, which is driven by a promoter, so that can ensure that the FOXP3 is always expressed at a very high level. And by doing so, these T effector cells become regulatory cells now, and they can function exactly like the normal T regulatory cells. In addition, this construct has like a flag that goes on the membrane of the cells, and therefore we are able to detect these cells that we infuse in the patient in the blood of the patient at different time points. So this is what we are using now for it's a sort of Treg replacement therapy. And of course, there are several publications about this, and a trial that is ongoing at Stanford that can be seen in more detail in the clinicaltrial.gov on the website of the FDA. So this is also an orphan drug designation, and certainly this is a phase 1 trial. So we don't know exactly if it can be curative or not, but at this point, but we have been treated 6 patients, and we can say that the treatment so far is safe. No one had any side effect. So the age is that we can enroll any age up to 35 years old and above 8 kilo of weight. The patient needs to have, of course, the FOXP3 mutation, history of IPEX manifestation, being refractory to treatment, and also we can enroll patients who had unsuccessful transplantation. The future is, and what is in clinical development is the modification of the stem cells of the patient with a different approach. This is a gene editing approach. So it means that we insert a normal FOXP3 gene exactly where the FOXP3 gene should go, and in the cells, in the genome, and in this case, we would replace the whole immune system with a normal functioning FOXP3. So this would really allow preservation of all the fine-tuned immune regulation that this gene has. And it should be also more long-lasting. So basically, this is all what I had to say. And of course, many people are participating to, over many years to the study, but of course to the trial that is ongoing. And Jesse Alexander is the clinical PI at the Stanford site. I really want to mention all the funding of the California Institute for Regenerative Medicine that has been sustained this study in the preclinical phase and now in the clinical phase, together with many donors from the Lucille Packard Foundation and within the infrastructure of the Center for Definitive and Curative Medicine. One more note that is very important, there is a website which is very active, you can find it, ipexfoundation.org, is really organized and maintained by patient and family, and it's a very good source of update and allows all the information and chatting and sharing history and story of patients and family with this disease. And thank you all very much for listening to me.
Wonderful. Well, thank you so much, Dr. Bachetta, for sharing all of that incredible information about your ongoing study and giving us a great overview of IPEX syndrome. We're so excited to be discussing that today. This is the first time we've covered IPEX syndrome in IDF programming, and it's very exciting. So thank you so much. And I do have more links to share in the chat, but for the sake of time, I'm going to keep going and then I'll share those links at the end. So if you are interested in checking out any of the studies or papers that Dr. Bachetta touched on in her talk, I will add those links at the end of the program. All right, wonderful. So we have a couple of minutes here and we're going to go through some audience Q&A. If you would like to ask a question, again, please enter it in the Q&A box in the control panel on your screen. We've shared a few ground rules at the top of the chat. If you could respect those, we would greatly appreciate it. And with that, we will go ahead and get started with Q&A. All right, so our first question, Dr. Bachetta, is in your talk, you mentioned that there are 600 patients worldwide who have been described as having IPEX and 200 different gene mutations. Given this information, what determines if someone has a diagnosis of IPEX versus another type of PI?
Yeah, well, the clinical manifestations are very important because generally primary immunodeficiency, as I said, manifest more with infections and not so much with enteropathy or type 1 diabetes, but definitely it must be, the gene sequence is the key for the certain diagnosis.
Thank you so much. So given that information as well, is the genetic diagnosis enough to know if IPEX is present, or is there any sort of additional confirmatory testing that an individual would undergo to truly solidify that they do in fact have IPEX syndrome?
Yeah, it's besides the clinical manifestation, there is the presence of autoantibodies that often are identified against the target organ, that are also, impaired and dysfunctional. But there are these tools that are very important, immunological tools, that can identify, well, whether there is a decreased expression of OXP3, sometimes lacking, although it's not very common, and also low T regulatory cells, dysfunctional T regulatory cells that can be assessed in specific laboratories. But I think I have found, a great utility in doing the TSTR demethylation. The increased frequency of cells in the blood with a high demethylated TSTR is really not failing in the identification and correlation with the FOXP3 mutation. So this is not yet a clear approved type of assay. Is still done in terms of research, but I have done this systematically over many years and many patients, and I find a lot of correlation and a lot of benefit that we have published.
Thank you so much. In your talk, you discussed that the available treatment options for IPEX syndrome are bone marrow transplant, of course, and then gene therapy, which is the clinical trial out of Stanford right now. How accessible are these treatments, and where would someone seek these treatments if they chose to do so?
Yeah, so bone marrow transplantation or stem cell transplantation should be accessible in any center that do that. Also for malignancies, but there are specific centers, like for example in United States, all the centers that are part of the primary immunodeficiency consortium treatment, where you have specific doctors that take care of patients with immunodeficiency. They can also treat IPEX syndrome with bone marrow transplantation. Even if the standard of conditioning and this can be different in a different center, because it's not really standardized for IPEX syndrome patients, but overall it's certainly accessible. And nowadays there is also the possibility of assessing in some specific center the use of stem cells from one of the parents. And so with alpha beta, so-called alpha beta T cell depleted haploidentical transplant, which also has been used for IPEX patients with success. And so this is for the transplant. But of course, going to the transplant, you have always many questions that needs to be addressed in terms of eligibility of the patients and so on. So, but definitely the patients should go to a center which has the ability to perform stem cell transplantation and, discuss with the physicians all the specific related to their case. Then for the gene therapy, so the one that is ongoing at Stanford as a Treg replacement therapy is a phase 1, is the only one that is ongoing in the world, so the first one and the only one, and right now is accessible to everybody in need. We have been enrolling patients from all over the world, and thanks to the funding that we have for this specific phase 1 trial. And in the future, we don't know where it goes, but for the moment, this treatment is accessible to every patient with IPEX, which of course meet the eligibility criteria.
That is wonderful to hear. And a sort of spin-off on that question, I was curious, is it a prerequisite for participation in the clinical trial out of Stanford that
Mhm.
an individual has had an unsuccessful stem cell transplant? Do they need to have had that first take place and have it not be a successful procedure in order for them to then go and through the gene therapy clinical trial?
No, no, sorry, I wasn't clear. So any patient with IPEX can have that, can assess this gene therapy treatment, including those that had an unsuccessful transplantation, but not only those that had an unsuccessful transplantation.
Thank you. That is so good to know, and that's so wonderful that anyone who meets the criteria will be able to be a part of the trial. That's super exciting for the IPEX community. So thank you so much. I think that wraps it up as far as questions. Dr. Bacchetta, I know you have the whole rest of your day to get to over on the West Coast. So we'll go ahead and let you move on with your day. But thank you so, so much for being a part of this talk this morning. Again, we are so excited to be able to add this to our lineup of educational resources for the PI and IPEX community. So thank you so much. And thank you to everyone for asking those great questions. We really appreciate your time today, Dr. Bacchetta.
Thank you so much. And please don't hesitate to reach out to me by email. So Emma, you can provide my email and I'm available to anyone for any question. Thank you very much.
Wonderful. Thank you so much.
Goodbye.
Goodbye. All right, everyone. Well, we are going to wrap up here shortly, but before we do, I'm going to share some information on IDF's latest resources and upcoming events. So be sure to check out our website for additional resources, upcoming events, and more. All IDF materials are free to access, print, or mail directly to you. And if your question was not addressed during the program, you can contact our board-certified patient navigator through Ask IDF. She will personally connect with you to tackle your question and to direct you to appropriate resources. And I'm sharing the link to Ask IDF in the chat now. And we also have a wonderful lineup of podcast series through IDF. You can find programs like Bold Conversations, Undiagnosed, and Chronic 20s by searching for the IDF podcast wherever you listen, whether it's on Spotify, Apple Podcasts, wherever you'll be able to find us. And we also have a YouTube channel where you can find recordings from all of our educational events. And this program will be available in the next couple weeks if you care to revisit it or share it with anyone in your circle. So I'll go ahead and share the link for our IDF YouTube channel as well. And we're excited to share that applications are now being accepted for IDF's 2025 Research Grant Program. This program supports research initiatives focused on improving patient outcomes and expediting the time to diagnosis for individuals affected by PI. To submit your project for consideration, download the application, which we have linked on the screen. Are you looking for ways to connect with others who are also navigating life with PI? If so, you might be interested in joining one of our many Get Connected groups. These groups are free, virtual, volunteer-led opportunities to connect with others with PI from all over the country. We do offer location-based groups or nationwide groups, and these groups meet on Zoom. So because they're virtual, you can join any group or time or leader, any preference that you have. And we also have groups for siblings, caregivers, and parents. Additionally, we offer facilitated support groups for young adults, parents, spouses, and partners. And IDF is offering several virtual screenings of our new documentary, Compromised: Life Without Immunity, via Facebook Live. And I'm going to share the link in the chat where you can find more information about when you will be able to participate in these virtual screenings. And applications have now closed for the upcoming Advocacy Day, but because we have spots available for our Young Advocates Academy, that opportunity still exists. Teens and young adults are encouraged to apply to make your voice heard, impact policy, and influence meaningful change for those affected by PI. And you can scan the code on your screen for more information about how to participate. Today's presentation kicks off an exciting start to our 2025 programming. We will continue to offer educational events and programs each month, and we host different programs throughout the year, so be sure to check our events calendar. And here's a look at what we have coming up in the next month. And we know our community members are full of great ideas for future topics that we can discuss during a presentation or even future presenters. So we'd love to hear from you. If you visit this link in your chat, we will consider your idea and get back to you. And maybe it'll be our future Lunch and Learn or webinar. And before we conclude, I want to thank everyone for joining us this afternoon. We greatly appreciate your participation, and we hope to see you back for more programming in 2025. Thank you again to Dr. Bachetta for leading this talk and providing this very important update for the IPEX syndrome community. Again, I'm going to add some more links in the chat, so if there's one that you're looking for, stay on Zoom for a few minutes and I'll pop that in the chat. And there's a couple in there already in case there's anything that you're interested in further exploring. Thank you so much again for joining us. Take care and have a great rest of your day.